Welcome back, guys. So today is the last session of our Mediclip, which I am doing actually. And today we have with us Dr. Priyanshu Maurya, who is the ophthalmology resident. And the topic what brilliant today is chemical injuries to the eyes. So yes, sir, over to you, sir.
Good evening, everyone. Good evening, Rohan. I'm Dr. Priyanshu Maurya, the third year ophthalmology resident from Shri B.M. Patil Medical College. I'll be talking about ocular chemical injuries. So, as we all know, ocular chemical injuries are the true ophthalmic emergencies due to potential damage to vision loss and visual impairment, and they can even lead to blindness. So, it's a serious threat to vision. Exposure can occur in various forms due to chemical agents such as alkalis or strong acids or alkalis, or even foreign bodies can cause a lot of reaction, which can lead to vision loss. So, talking about ocular emergencies, the prevalence is about 1 lakh. So, it's a really serious problem. It can cause about blindness. A study has shown it causes blindness about 1 lakh population per year. So we need to consider this serious problem and give immediate intervention accordingly. So coming to the causes of the ocular chemical injuries, it can be either due to alkali or acid as told. Also, the most important factor in these injuries is the concentration pH of the solution, which is being which goes into the eye, right? And also it depends on the exposure of the eye, like what part of eye is getting exposed, and the duration to which before treatment, how much was the duration to which the chemical agent was exposed. So the visual outcome or the prognosis depends on basically these three factors. So coming to the injuries as such, we know it can be caused by alkali or acid. Usually alkali burns are more harmful. The simple reason being the alkali causes more penetration of the tissue. Alkali dissociates into hydroxyl ion, which causes more penetration, and also it results in change in the pH of the aqueous humor compared to acid. Acid, on the other hand, it causes the precipitation of the epithelial proteins. So what happens is it results in a barrier formation, so which prevents further penetration of the acid into the intraocular tissues. So that is one of the reasons why alkali burns are more harmful. Alkali burns can be due to various causes: sodium hydroxide, potassium hydroxide, or calcium hydroxide, which is lime, which is very commonly used in plasters or in construction workers. Also, sodium hydroxide, which is also known as caustic soda, which is also very commonly used. And also, it has been seen that these injuries are more prone into young population. So it becomes even more important to give timely intervention as to prevent the vision loss or to have good visual prognosis. Then coming to the what step has to be done as soon as the patient comes to emergency room with such conditions. So the immediate management of the acute injuries of such conditions is to give copious irrigation. Right, we have to give a thorough saline wash. Thorough saline wash, ideally it has to be about 500 ml to 1 liter. So that what happens is in most of the cases, these foreign bodies can get lodged in the tarsal conjunctiva or somewhere in the conjunctiva or in cornea. So a thorough wash will, what it does is it removes the debris or whatever the materials are present, whatever the injury agents are present, it removes those agents. So it becomes extremely important to give a copious irrigation. After copious, in a study, it has been shown that about copious irrigation for 90 minutes, it reduces the pH to about 1.5 units. So it's quite considerable, but the duration of this irrigation is too much. About 90 minutes giving irrigation, it sometimes becomes unpractical. So what can be done is at least 500 ml or 1 liter of saline thorough wash should be done. Immediately after the wash, what we can do is we have to look for any foreign body. Look for conjunctiva, if any foreign body is lodged there. Evert the lid, double eversion technique is there. We can evert the lid and see if any foreign body is lodged over there and remove with the cotton swab. What happens is sometimes this foreign body can be painful also. So we use a topical anesthetic agent, although it's not very much recommended because topical anesthetic agents are known to cause they are actually epitheliotoxic. So it shouldn't be used in too frequently. It's just so that patient becomes comfortable and you can remove the foreign body. That's it. That's the only symptoms of using topical anesthetic in such conditions. After copious irrigation, you have to look for signs of inflammation. So there would be ciliary congestion or conjunctival congestion. So you have to treat it accordingly. inflammation can be controlled by using topical steroids. Okay, so usually in there is a one classification, Roper Hall classification, where we see if there is any limbal stem cell involvement or what is the clock hour of limbal cell involvement. Based on that, we have to plan our treatment accordingly. Initially in grade 1 and 2, usually we don't start on steroids. We look for any limbal involvement and what clock hour is it involved. If it's more than 3 clock hour involvement, or if limbal ischemia is more than half or one third to half, then we go for steroid treatment. Another thing is to start, usually these patients with the chemical injuries, they will present with some or the other type of epithelial defect or some sort of keratitis or epithelial erosion. That has to be there. That in most of the cases, about 99% of the cases, it's there. So what we do is look for signs of any corneal erosion, and we stain the eye with fluorescent stain, see under cobalt blue filter, and look for signs of corneal erosion. If that is present, immediately antibiotic eye drop and preservative-free lubricating drops has to be started. What it does is, what we are doing with this is we are reducing the inflammation with steroids as well as preventing any secondary infection by use of antibiotic. Usually the antibiotic which we use are fluoroquinolones, moxifloxacin, gatifloxacin. These are all fourth generation fluoroquinolones. They are known to have better penetrating power. So it reduces, and also they are broad spectrum antibiotic. So they are known to prevent the secondary infections. Also, lubricating drops have to be used, such as methyl cellulose or carboxymethyl cellulose or even hypromellose. All these are lubricating drops. These are basically to reduce the secondary infection and promote the corneal reepithelialization, which is very important, because once the epithelium gets eroded, it becomes very easy for microbes to penetrate the eye, and they can cause severe sort of intraocular inflammations. So basically, we have to stop the intraocular inflammation. So that's why I told you in the beginning also, like the duration of the injury is very important. When you start the treatment, that becomes very important in such condition. So as soon as a patient comes to you in any setup, I think the best you can do is start for the copious irrigation, wash how much you can, look for signs of any corneal erosion or anything, start on topical antibiotics, and see if any limbal involvement is there. If limbal involvement is more, you can obviously go for corticosteroids. And also there are a few surgical management. Those are actually secondary treatments if any ectropion is there or entropion is there or any lag ophthalmos, because patients with such injuries, chemical injuries, they are known to cause such conditions where you will have outward rolling of the or inward rolling or lag ophthalmos will be there, or any corneal tear can present, or there can be also dry eye. So these are the most commonly presenting symptoms. Also, one of the most threatening signs or most threatening signs which you should always look for is limbal stem cell deficiency, because as we know, limbal stem cell, as the name suggests, it is a pluripotent stem cell which is capable of producing the epithelium. So once that get involved, it becomes very difficult for reepithelialization of cornea and conjunctiva. So once that doesn't happen, again the same cycle will continue. Microbes can infect and epithelial erosions will happen. Ultimately, it can lead to corneal ulcer or even corneal melt in severe cases. So that is the basic overall regimen of the treatment of the any chemical injuries.
Sir, so questions what we have is the first question is, suppose a patient comes to you after 2 days of the chemical injury, then what will the management differ? How will
See, as I told you earlier, the duration is very important. That is the critical time when patient appears to you. When patient first time comes to you, even if he comes after 2 days, you have to start the basic treatment of copious irrigation has to be done, because you never know, foreign body would have been lost somewhere, which would have lost somewhere in 2 days. And also they would have clustered and formed some sort of debris in the conjunctiva or in the upper tarsal conjunctiva or cornea or somewhere. So the treatment still remains the same. You start with copious irrigation of 1 liter or about 500 ml. Look for the debris, look for the foci of whatever the agents are there, whatever any alkali or acid is present. You have to remove that with the cotton bud or applicator. You have to remove them. Start on oral antibiotic. Look for the same signs. Look for any limbal stem cell deficiency or anything. If it's there, start on oral steroids or topical steroids. If it's if more than 5-6 hours are involved, you can even start on oral steroids. So management remains pretty much same. Just you have to look for any foreign body and remove those agents. That will be the best line of management. Yeah.
Yeah, so next what we have is, sir, what is Morgan lens and how it is useful basically in case of chemical injury?
See, Morgan lens is basically a device. It's like a contact lens only, which gets adhered to your cornea, and it basically doesn't physically touch your cornea. And also, it has a tubing system, which continuously irrigates your entire eye. So, as I told earlier, copious irrigation is important. So, 90 minutes being physically holding with the hands and putting irrigation is not possible sometimes. So, what usually in our setup or in rural areas, if you see, I don't think Morgan lens is used as much. It's a more of a practice which is done in developed countries. So, and also I think device is quite costly. So it usually is not used in our setup. But say Morgan lens has a dual benefit of protecting the cornea as well as providing continuous irrigation, which is not physically possible.
Yes, we have. So as you said, alkali injuries are more difficult, basically difficult to treat.
Yeah,
So why, how it differs
yeah,
basically from acid and alkali in terms of treatment
yeah.
management?
Yeah, about that I already told. Alkali injuries, as you know, it breaks into hydroxyline. Hydroxyline, what it causes is saponification. There's a process called saponification of the plasma membrane, which will further lead to cell loss and cell destruction. And also, it alters the pH of aqueous humor. This alkali agents, so they alter the pH of the aqueous humor and causes even more penetration, and it can even lead to retinal detachment or problems in retina. So in that way it acts. While acid, on the other hand, if you see, it causes the precipitation of the cell membrane proteins. So when that happens, precipitation, it actually forms a barrier. So with formation of
Mhm.
barrier, it prevents further entry of the acid. So in simple terms, if you ask me, alkali causes more penetration due to so and so reason, as it forms hydroxyl which causes more penetration. While acid, on the other hand, causes less penetration due to formation of a barrier causing precipitation of the protein. Yes.
So as you said, we should not use anesthetic, basically topical anesthetic. But if we want to use,
Uh,
so what will be the topic anesthetic of choice, topical, in case of chemical injuries?
uh, See, for you ask me honestly, there is no such thing like ideal anesthetic in chemical injuries. It's just for that the you want to make patient cooperative to remove the for irrigation and to remove the foreign body, because a lot of time the patient will be in pain and those foreign body will cause irritation, and a lot of watering and all those things will happen, itching and all those things, foreign body sensation. So what you want to achieve with the topical anesthetic agent is you want to reduce all those sensation, basically corneal sensation, so that you can remove the foreign body aram se. So that is the regimen. Usually we use 0.5% paraquin. That is what we have been using. But I don't think it's like anything called ideal anesthetic in such
Mhm.
condition or such. Yeah.
Okay, so next we have to, as you said, limbus stem cell. So what is the viability of the limbus stem cell in case of chemical injuries? And how will you diagnose it? How will
See,
you tell it is there or not?
yeah, limbal area, what we have to look is once you look in the cornea, limbus is basically the area where cornea and conjunctiva are attached. That is where stem cells
Mhm.
are found. Those are pluripotent stem cells. So how the reepithelialization occurs is the stem cell come, and usually the migration happens from periphery to center. So the healing process starts from peripheries to center and also from inward to outward, if you talk about the corneal layers. So what we are looking for basically in limbal stem cell viability is if any pale areas of around the limbus are seen, and that is what we are quantifying in the clock hours. If one clock hour is involved or two clock hours are involved, based on the area, how it looks, pale area, other area will be congested. If you see, compare with the limbal area, it might be of pale color, so or white color. So that is how you know ki the limbal stem cell is not viable in that region, and based on that you quantify like what is the grade of injury and what further. As I told, grade 1 and 2, you need not to start on corticosteroid initially. Later you can switch to corticosteroid if you feel limbal stem cell viability is lost or any deficiency is there. Yes.
Okay. So next what we have is how will you deal your chemical injury in low setup areas? Like when suppose if you want to give a first aid and in the rural areas,
Yeah.
so what will you do?
Yeah. See, in the first aid in this thing condition is that thing only copious irrigation. That I think NS is readily
Yeah.
available at all setups. Yeah. So what you can do is wash the eye thoroughly. So you see for wash and retract the lower lid, wash there, retract the upper lid, double immersion technique. Look for any foreign body, give copious irrigation there. Ask the patient to look on the left side and you irrigate the right side. Ask the patient to look on the contralateral side and you irrigate the other side. So that is how you do irrigation and remove the foreign body. That is the basic minimum I think that can be done, even if anything is not available. And also, I think prophylactically, it's always better to start on antibiotic. As I told, there will be some sort of epithelial erosions or some sort of epi defects. So that should get covered with antibiotic and lubricating drops. I think that is the bare minimum which can be done in such setups. Yeah.
Yes, and the last question what I have is how hydrofluoric acid injury, which is used in glass polishing, different from other acid injuries to the eye.
Okay, so hydrofluoric acid is actually a weak acid. If you talk about it's a weak acid compared to other acid, sulfuric acid, sulfurous acid, or hydrofluoric acid. But the thing with hydrofluoric acid is that it dissociates into fluoride ion. Okay, so what happens is fluoride ion is known to have more penetrating power. Okay, it has more diffusing property. It has more penetrating power. So as I told, usually acid will cause precipitation and will form a barrier. Now, hydrofluoric acid being a weak acid, it doesn't cause that much of a precipitation reaction. And so that barrier is not formed. So if that barrier is not formed, so this weak acid can penetrate more. So again, the thing comes to that only. As we told, the alkali have more penetrating power than acid. So it also, compared to that, this also penetrates more. And it goes into the aqueous humor and can even go beyond that and cause further issues. Yeah. So that is basically the difference. It's being a weak acid, it dissociates into fluoride ion, which has more penetrating power.
More penetrating.
You can say in that terms. Yeah. Yeah.
So yes, coming to the end of the session. So yeah, thank you so much for joining.
Yeah. Thanks, Rohan. It was very interactive session. I would like to congratulate you and your team. You're doing a fantastic job, man. We'll see if further we can have more sessions such. It's quite helpful for, I think, for everyone, even you and for all the aspirants. Yeah.
Yes. Yes. Thank you so much.
Thanks, Aman.